hasn't yet risen to its normal location. But by the 4th and 6th week, the adrenal is already well underway towards developing the cortex, relatively independent of the medulla. The medulla coming from neuroectoderm and neurocrest cells. It's also important to notice that the adrenal cortex is very close to the mesonephros. And so when the gonad does develop and descends into the scrotum, you can sometimes pull some adrenal rests with it for this precise reason. And in 3% of children who undergo groin dissections, you'll find a small little yellow island of adrenal cortical tissue. By the 8th week, steroidogenesis has really begun, but only the zones that handle the production of mineralocorticoid and glucocorticoids, not the sex hormones, the zona reticularis. That really only becomes functional by the child is between 3 and 5 years of age. I promise this is the only image like this you'll see this morning, but I just want you to look down here in the lower left. You can see here in the fetus, estrogen blocks the activity of 3-beta-hydroxy dehydrogenase. And because of that, the fetus doesn't make his or her own aldosterone and his or her own cortisol. And I think that's protective to the mother. The mother's making plenty of these hormones and the fetus doesn't need to add to the soup. But what it does mean is that these precursors end up going in these other pathways towards the production of estriol. And for many years, estriol was used as a surrogate marker of fetal brain activity. So if you had no estriol and no fetal movements, that's obviously a rather dire sign. But it also means that the infant's or the embryo's adrenal gland feels understimulated because it has no internal feedback. And for this reason, the ACTH of the fetus goes way, way up. And for that reason, because of the suppression by estrogen, the adrenal gland in the fetus is very large. Cortisol production is very low. It's almost Addisonian in a way. And so the ACTH stimulates the adrenal growth so that the adrenal gland is up to 20 times larger than its adult size relative to the kidney. What happens after birth, of course, is in the lack of estrogen, the adrenal gland rapidly involutes, so much so that during birth, especially birth trauma, these large vascular adrenal glands can hemorrhage. It's the reason we see adrenal calcifications on incidental scans. So the normal adrenal gland has long been known to be a paired deep retroperitoneal organ around the 12th rib, but laparoscopically you could appreciate that it's much more cephalad than that. Very small, only 5 to 6 grams. As we said, it arises really independent of the kidney. So in the absence of the seminal vesicle and the absence of the kidney, you'll still have a normal adrenal gland on that side. Now, zonation is important. We all know GFR, we all know salt, sugar, sex, but it's also important functionally because you can see here the cortex wrapping around the medulla is not just an anatomic convenience, but cortisol production in the cortex will percolate down through the cortex into the medulla. And it's thought that cortisol production is important to optimize function of tyrosine hydroxylase, which, as you know, is the rate-limiting step in catecholamine production. So the medulla may function well without the cortex, but the cortex optimizes medullary function. It's also important to note that the main site of ACTH stimulation is really only on the zona fasciculata, not the zona glomerulosa, which is, of course, the area for glucocorticoids, for mineralocorticoids, and that the adrenal does not make really any androgens to speak of until the child is well into toddlerhood. Now, the vascular anatomy of the adrenal is surgically rather important. Certainly with partial adrenalectomy, you're going to be using a ligature or whatever device to really resect a lot of the adrenal, leaving behind sort of just a rim that you hope is going to be perfused. And generally it is well perfused, except in periods of stress. You can see here that that you can divide the main vein to the adrenal gland, and it will still drain well through these parasitic accessory vessels, usually superiorly and medially, except in periods of stress. So if the adrenal gland is tasked to make a lot of hormone and needs to hypertrophy that main vein may not be sufficient to acutely, at least, accommodate the change in volume. So just a slide before a movie, the adrenal venous anatomy is rather infamous or famous, and we know laparoscopically that we were all taught to attack the adrenal vein first and then open up the adrenal vein from its other attachments and proceed towards its enucleation. But this is sometimes not always the case in large masses. The arterial anatomy is not insignificant. You can see here that most adrenal glands derive two arterial sources. One is from the renal artery, very rarely directly from the aorta. But on the right side, the subhepatics, and on the left side, the subphrenics will perfuse the adrenal gland. Some teach that it's easier to attack the adrenal vein if you divide these small little parasitic arteries first. It not only decreases adrenal perfusion, but may make the adrenal a little more mobile so that when it comes to dividing the adrenal vein, there's a little bit more laxity. This is sort of illustrated by a recent case we did. This is a 10 centimeter pheo and a relatively stable guy. And here we are dissecting. This might be a little shaky, but here we are dissecting the main adrenal vein on the right side. You can see immediately would be the caudate lobe of the liver. And this is clearly an older video. A ligature would be adequate to divide this without clips. You can see here that when you put a clip on, you sometimes run out of real estate. Now this clip goes on and punctures the lateral aspect of the adrenal. And normally this wouldn't cause a problem. You can see here there's a brisk flow of blood. And it shows you that kidney, that adrenal was as large as a kidney. And those arterial sources were relatively significant. So our error was not dividing those adrenal arteries, these little adrenal arteries first, decreasing perfusion, and then going for the adrenal vein. So that's just a correlation of anatomy and how that can be significant surgically. Now the neurological, and I do have a timer here, so I do know when to stop. Neurologically, the adrenal gland is famously innervated by preganglionic sympathetic fibers because the medulla is, in a sense, a ganglionic structure derived from sympathetic onlaga. So most of these fibers are preganglionic and innervate the medulla. Some of them will actually break free and innervate the juxtaglomerular apparatus, which is an interesting link between the adrenal medulla and the adrenal cortex. So just a little bit about adrenal pathology, and this is a relatively significant image here. You can see, for those of you who are younger, who may not recognize these people, this is President Kennedy and President Eisenhower, and both of them were afflicted by adrenal disorders. So what are the odds? There's 46 presidents, so 2 divided by 46 is a relatively high incidence of adrenal pathology amongst chief executives. Now, Kennedy's problem underlying everything was an autoimmune adrenal insufficiency due to an antibody against 21-alpha hydroxylase. But he was treated with cortisol, and in a time where cortisol treatment wasn't really well worked out. And so he was often either Cushingoid because of too much cortisol, or when the cortisol ran out and didn't receive another therapy, was Addisonian in a way. And when he was running for president, a lot of criticism on his health, beyond his Catholicism, was on his health, and that some had claimed that he had Addison's disease, and it was made clear in a Newsweek editorial that he did not have Addison's disease, which classically was described by Thomas Addison, which was a tubercular destruction of both adrenal glands causing adrenal hypofunction. And because Kennedy did not ever have tuberculosis, he therefore didn't have Addison's disease, although he was Addisonian. Of course, metastatic disease can rarely cause adrenal hypofunction if you destroy both adrenal glands. And rarely, I've seen one case in which there's been pituitary destruction and causing low ACTH, and you can lose adrenal function that way. It's important to remember in Waterhouse-Friderichsen syndrome, this is the sepsis associated with with bacterial infection, that this can cause adrenal hemorrhage and necrosis. Hyperfunction is more important for us surgically. It's clear that adrenal cancers will be hyperfunctional, but we also will have those cases that come to surgery because of hyperfunctioning medullary or cortical rims. Interestingly, the most cited emergency in all urology is actually a child born with ambiguous genitalia. The most common cause of this is, of course, congenital adrenal hyperplasia, which we won't get into much today, although it's important to note this is one of the more common reasons associated with ambiguity of the genitalia. Then there's the non-functional adrenal masses, and some of these are surgical because they're 6 centimeters or larger, but some of them are relatively incidental. And as Lord Kelvin used to say, nothing exists unless it's measurable. In the United States, nothing exists unless you have an NIH consensus conference about it. So the incidentaloma was first discussed at an NIH consensus conference in 2002 because it was clearly the most common way an adrenal mass was diagnosed, was incidentally. And the incidentaloma guidelines were, and these are relatively applicable, is that all patients with an incidentaloma should at least be considered as having a workup for functionality, and to determine if a patient had Cushing's, Cushingoid adrenals, a 1 milligram low-dose dexamethasone suppression test was usually sufficient to rule in or rule out for the workup. It's also a low-risk test. It really requires just an intravenous puncture. And some have also obtained plasma-free metanephrines at that same moment. You withdraw the blood, send it off, and then you give the 1 milligram dexamethasone, and then you come back later to measure your cortisol changes. It's also recommended that any patient with hypertension who has an incidental adrenal mass should undergo at least measurement of serum potassium, because this is probably acutely more worrisome cardiologically than long-term catecholamine excess. A low attenuation value on a CT scan is almost certainly a benign adenoma, and we'll show you a slide of those lesions that have very low Hounsfield units, i.e. in the negative range. And remember that surgery should always be considered in a patient who's a surgical candidate who has functional adrenal cortical tumors that are clinically relevant. So it is arguable that some elderly patients with an aldosteronoma might be medically managed. Some who are younger might be better managed surgically. And even in bilateral adrenal hyperplasia, you can often argue that one side may be more dominant than the other. Of course, that's different than pheochromocytoma, where it's generally recommended that almost all patients undergo adrenalectomy. And the guideline for those with bilateral pheochromocytomas, or those syndromes in which patients are predisposed to redevelop pheochromocytomas, is to at least consider a partial adrenalectomy. I was very proud of myself. One of my first cases was an adrenalectomy in a von Hippel-Lindau patient. And in the recovery room, he was aghast that I hadn't considered a partial adrenalectomy. So it just goes to show you that a lot of patients know a lot more about the indications for things than we do. Luckily, that particular patient's adrenal gland was 8 centimeters, and it wouldn't have been very easy to do a partial adrenalectomy, but it's still a very important point in small 1 centimeter, 2 centimeter lesions. And in general, patients who have a adrenal mass greater than 6 centimeters should be considered for surgery. And those between 4 to 6 centimeters is the gray zone. Those are the ones that might be considered for further workup. Just a note on the adenomas. If you get a CT scan, make sure it's a triple phase CT scan. And this is really the best way to rule in or rule out a lipid poor adenoma. If an adenoma has a lot of fat, it's really quite easy. But some of these adenomas are very difficult to rule out a functional tumor or one that needs to come out, especially in the gray zone. So the hallmarks of a lipid poor adenoma would be early washout in the triphasic CT scan. That's an early clue. Another one would be any mass that's less than 4 centimeters. So a small mass that has early phase washout is almost clearly a benign lesion that can be watched. Now, what about these masses? You can see these are 2 patients of ours. These are very large masses. Clearly, these are coming out. But the dark areas here are consistent with fat. And in fact, the Hounsfield units generally are between -30 and -100. And these large lesions are often space occupying. And when they become very large like this, it can cause some respiratory embarrassment, pain, and lateralizing findings. And when that's the case, you generally have a good indication to do surgery in a large myelolipoma, rather than somebody who has an incidental myelolipoma that's, say, 5 centimeters without any symptoms. You can find calcifications in these, but I believe it's reportable if you find an adrenal cancer within a myelolipoma. At least I haven't seen that reported. Another important cause of an adrenal mass is hemorrhage. We don't think of hemorrhage much because we don't see these patients who are acutely ill, but sometimes patients will develop a hemorrhage, recover, and then we see them later with a calcified mass. The most common cause of hemorrhage, of course, would be sepsis. The meningococcemia is the most infamous cause, but any kind of sepsis ought to do it. There are some patients who develop DIC. It's obviously unclear if DIC is etiologic or it's just in the setting of sepsis and anticoagulation. Antiphospholipid antibody syndrome is also associated with adrenal hemorrhage, especially in the settings of heparin-induced thrombocytopenia. And it's important to note that the adrenal on the right side is more prone to hemorrhage from trauma than on the left side because its closeness to the spine. This is an example of a CT scan of a patient who came in for incidental reasons who had bilateral adrenal calcifications. These are quite obvious. These may have been sustained even in birth trauma and are generally incidental. Now, what are not incidental is, of course, malignancy. Now, the most common malignant tumor of the adrenal gland is a metastatic lesion. The most common of these in the United States, anyway, is lung, and followed by breast and stomach. Now, in some Chinese series, esophageal cancer metastasizes to the adrenal gland and takes over this number 2 spot. But we can also find a melanoma. And of course, the 2018 AJCC guidelines has changed the staging of kidney cancer depending on how it metastasizes to the adrenal gland. Contiguous involvement of the adrenal gland is now thought to be more of a T4 lesion, whereas a drop metastasis spread by hematogenous or lymphatic spread is now thought to be an M1 lesion. I think that was one of the questions we got wrong on the AUA quiz, and I think the judge should have looked that one up. Now, indications to be concerned about malignancy, of course, would be a very large tumor, a large mass. Any patient that elicits 17-hydroxycorticosteroids are worrisome for having an adrenal tumor, and I think that that's one of the things you can get in the office evaluating anybody with a large adrenal mass. Of course, Cushingoid signs, virilization in a child or in a female, and feminization in a male. One of the most common findings is acne or rosacea changes to the face. It's a very grim prognosis with a very minimal 5-year overall survival. And classically on the in-service examination, the treatment was mitotane, which is a derivative of DDT, which is the insecticide. Now, this is an important slide because it launches our physiology section of the talk. And what more fascinating at 7:30 in the morning than the macula densa? This is really a critical structure for adrenal physiology. As you know, the macula densa is present in all vertebrates except in the kangaroo rat, where it's very, very long and can help concentrate the urine. It's not present in reptiles, and they have a very difficult time concentrating the urine. But what the macula densa does do is, through prostaglandin secretion, will stimulate the juxtaglomerular cells to make renin. The renin, of course, goes off, and we eventually get back angiotensin II. Angiotensin II constricts both the afferent and the efferent arteriole, but more the efferent arteriole to help improve GFR. So on the in-service examination, one of the reasons why angiotensin II can be increased is because of low distal tubule sodium and also low blood pressure. Now, this is important because the juxtaglomerular cells can also be stimulated by the sympathetic nerves. It takes a while for aldosterone to be made. It has to be transcribed, it has to be translated, then post-processed. So if a patient is hypotensive and needs to reclaim sodium, it's going to be several hours before the aldosterone can be secreted. So it's thought that sympathetic innervation of the juxtaglomerular cells can occur with anticipation. If a patient is anticipating dehydration, or if they believe they have to walk 30 miles to get gasoline, then the sympathetic nervous system will turn on and hopefully pre-initiate the production of aldosterone. Aldosterone, of course, as you know, its main function is to influence the epithelial sodium channel, or ENaC. So you can see it here, it takes quite some time. It's not as quick as, say, ADH function. It takes several hours for aldosterone to be made and then to cause sodium reclamation and potassium excretion. Now, aldosterone is mostly, but not wholly, independent of ACTH stimulation. We know that cortisol will optimize aldosterone production. It is almost wholly dependent upon angiotensin II stimulation via the renin system. Also, feedback is very poor. Once you make a lot of aldosterone, there's no feedback to turn off the production. It's really dependent on the electrical and electrolytic changes that go on. Now, this important individual, this good-looking individual, is a fellow New Yorker who was born in Brooklyn and was named Jerome Cohn. He eventually went to Michigan, and this is his Facebook picture at the University of Michigan, where he matriculated. He went there for med school and then changed his name to Jerome Kahn for some reason. And he was very interested in sweat physiology. And it was thought that aldosterone and sodium were very important in sweat physiology. But then he came to realize that it was also important in management of blood pressure and its production in the adrenal. His first patient was a young female who had such severe myalgias that she couldn't walk. She didn't have a neurological paralysis, but she just couldn't walk. Hypertensive. And strangely, whenever she would eat Chinese food, the paralysis would get worse. So clearly she was developing a hypokalemia and hypernatremic alkalosis. This alkalosis may or may not be present in patients who are compensating well. And this is where we rely on our nephrology colleagues to do those complicated formulas to find out if somebody is appropriately compensating for their alkalosis. But importantly, they're not edematous. So they have myalgias and are not edematous. So he referred this patient to a surgeon. There was no imaging, and so they did a bilateral lumbar approach, identified the adrenal mass, and I'm going to say it was on the right side, even though it could have been the left. We're 50-50 on that. But they removed the tumor, and a few weeks later, the potassium normalized. You can see here, this is the old approach. It looks straightforward. I can tell you, having assisted the great Bernie Litton in two of these, this is a deep hole, and it's not easy to see the adrenal gland this way. I have a video from Germany that shows the retroperitoneal approach to this, much more direct and feasible. This is one of the more important keynote lectures he gave. Curiously, at the John Phillips Memorial Lecture, 1965, I don't recall giving my permission for that, but this is where Jerome Cohn received an award for describing what now is known as Conn's syndrome of hypokalemia, suppressed plasma renin, and high urinary and plasma aldosterone. Clearly, there's primary aldosteronomas. This is the one where we see the need of adrenalectomies. But the secondary ones, you don't want to be taking out somebody who has high aldosterone and high renin, because these are generally compensatory. So you'll probably be making something worse. And these are low volume states, hypoalbuminemia, renal ischemia. I'd love to see a patient with a juxtaglomerular tumor. These are generally hilar masses in the kidney. And I got to give you credit if you see one of these and you think about getting a renin. This is an interesting situation, a patient of ours who had bilateral adrenal masses. You can see here that this is a right-sided adrenal mass, and here's a left-sided one. This is macronodular adrenal hyperplasia. And these are sometimes incidental, but sometimes associated with hypertension. And as you know, many patients who are on antihypertensives have really crazy laboratory studies. Their aldose may be normal, their aldose may be high, their potassiums may be normal because they're taking K-DIR. And so it's important to figure out if one of these sides is dominant. And the best way to do that, of course, is with lateralizing studies with adrenal vein sampling. As a resident, I used to think that you put a catheter in the adrenal vein and out gushed adrenal blood. But if you ever participate in these things, you notice that it's really a trickle at best. And it's actually very difficult to get a pure sample. And so this is one of the reasons we also check a cortisol level at the same time, driving what they call an aldosterone cortisol ratio, AC ratio. And this is the thing that you need to look at, not the aldosterone level itself. And you can see here that we also, this is a paper of ours from eons ago, that we also like to get ACTH levels before, we like to get these levels before and after ACTH stimulation. A lot of interventionalists don't do this because it takes time and they're already overbooked. But you can see here that in benign adrenal hyperplasia, there's really no change, if any, of suppression in their AC ratios. Whereas in almost all primary adrenal tumors of aldosterenomas, you can see that most of these will increase their AC ratios. And generally, the contralateral side is suppressed. Now, adrenalectomy in those patients is often associated with chronic renal insufficiency. And the reason it's important because the high aldo levels can mask underlying renal insufficiency. If you think about these patients, afferent and efferent arterioles are constantly under some sort of vasoconstriction. And then when you release that, the GFR may rise to a higher level. And we're trying to figure out globally what are predictors for elevated creatinines after an adrenalectomy for aldosterenomas. It's something to be cognizant of. It doesn't mean that there's been surgical damage to the kidney, but those patients generally have to be referred to nephrology for a workup. Now, in the last few minutes, I think 22 minutes to give the next speaker time, we'll just speak about the more exciting tumors of the medulla. This would, of course, be the pheochromocytomas. These are rather interesting tumors. We share them with our general surgery colleagues, and it's surprising to find how many patients with the pheochromocytomas are really asymptomatic, that they may have hypertension, they may have other findings, but they really aren't the people that show up with catastrophic hypertensive crises. So once you see a few of these, you'll see that there's quite a broad spectrum. They're still very rare, and they're very rare in patients with hypertension, but over a career as an internist, you probably will see maybe 4 or 5 patients who have a pheo. It's very common in patients with neurofibromatosis. So if you have a patient with von Recklinghausen's disease or neurofibromatosis and they have hypertension, half of those patients will have a pheo. So those patients are clearly going to benefit from screening. It used to be taught that this is a tumor of the 10-10-10 rule, now not thought to be accurate. One of the 10s was 10% were hereditary. It's now thought that if you actually look at the germline, you can find germline mutations in one of the many genes in up to 30% of the patients. Interestingly, this is a disease of volume contraction, like Conn syndrome, no edema, but also no muscle cramping because the potassium would be normal. Here are 2 examples. So we saw that Kennedy had adrenal hypofunction from the cortisol levels, but President Eisenhower actually died many years of heart disease, and at autopsy he had a small adrenal tumor. This is written up in the New England Journal, which is a white journal read by internists, and he had a pheochromocytoma, obviously indolent, not known, but certainly contributed to his cardiomyopathy. And you can see here that, well, this isn't a very controlled study, but these are some of his blood pressure readings over time, that he was consistently hypertensive during certain episodes. And then you have another patient like here on the right. This is a large pheo, and these are really significant clinically because the patients get used to having a lot of catecholamine circulating. And then when you clip off their adrenal vein here during surgery, you can see this rather large drop in blood pressure. Now, we see pheochromocytomas mostly in sporadic cases, but it's important to know about at least VHL, because if a patient comes in with a PHIO, I think we should examine them to make sure they don't belong to one of these families. I don't think it's going to harm us. Just a nod to von Hippel, who was the ophthalmologist, and Lindau, the Swedish pathologist, who sort of put it all together. So it wasn't a urologist or an endocrinologist that described the syndrome, but an ophthalmologist who noted that retinal angiomas was a hallmark of disease. And for some time, we had ophthalmoscopes in our office to examine people's eyes. Clearly not easy to do without dilating them. And then OSHA took them away. However, there are definitely two clusters of patients who have pheochromocytomas, depending on where the gene is mutated. So the first cluster are those patients with von Hippel-Lindau disease, and those that have inherited mutations in succinate dehydrogenase. These tumors are driven through HIF1 alpha and in the same sort of pathway as kidney cancer. The other cluster are those in, say, von Recklinghausen's disease or MEM2, where they mostly have mutations in NF1 or RET, and these are more in the line of oncogenes and apoptotic escape. So you can see in VHL, we really need to know that retinal angiomas, spinal tumors, ear tumors, adrenal tumors, and kidney tumors are the hallmark of VHL. But I think a lot of these things you should be able to pick up on a CT scan and physical exam. A neurofibroma is a relatively obvious thing to find. And again, if a patient has one of these lesions and is hypertensive, they almost certainly have a PHIO that needs to be ruled out. Here is a cafe au lait spot. You can see the coast of California borders, which is a hallmark of these disorders. Now, the signs, of course, are relatively common. An interesting sign, of course, is hypotension. I always think of these people as being hypertensive, but in fact, people who have long-standing catecholamine excess may in fact have trouble mounting high blood pressure and are hypotensive, and may come in looking very sluggish, which is a rather interesting finding. A lot of them can have facial pallor because of facial vasoconstriction, but most of them complain of palpitations, tachycardia, blurred vision, etc. Diabetes is not uncommon, and there are many patients who walk around with anxiety disorders who, in fact, have an underlying PHIO. Now, a little bit about adrenal development with the medulla. You can see here, this is a tadpole embryo. You can see quite clearly that the neural crest cells are really important in every onlog of the body. And that's important to realize that if you think of the neurological system, the peripheral neurological system, as these nerve roots, the more cranial and caudal nerve roots will obviously end up being the parasympathetic ganglia. These generally do not make catecholamines and generally are not standing for chromaffin. The other ones are sympathetic. And you can see here that this circle goes to this lateral lesion. These would be the sympathetic ganglia of the main chain, and this is the medulla of the adrenal gland. These make catecholamines and are chromaffin positive, but only this lateral lesion will be a pheochromocytoma. So there is no such thing as an extra-adrenal pheochromocytoma. That's according to the World Health Organization, so you can take that to the bank. So if you say somebody has an extra-adrenal pheochromocytoma, we know what you mean, but it's not true. Now, what that does mean is that all these other tumors that you find, even close to the adrenal gland, is actually a paraganglioma. And so the pheochromocytomas are seen in the VHL families, the von Recklinghausen's families, and the paragangliomas are seen in the PGL families. Now, the microbiological link to this is, of course, the mitochondria. And we know that the mitochondria is a beautiful organelle derived from ancient bacteria. And on the inner membrane of the mitochondria sits a whole host of enzymes, not the least of important of which is this little red guy here, obviously just a cartoon. And this is succinate dehydrogenase, which is an incredibly important enzyme, folks, because it's involved in not only the Krebs cycle, but also in this important electron transfer chain, which, as you know, is the only way we make ATP. And the trivia question of the day is that the only reason we need oxygen is because it's the ultimate acceptor of this electron chain. Now, ubiquitone is an important enzyme everywhere, but this enzyme here is important in transferring these electrons down the chain towards the production of ATP. So this is succinate dehydrogenase. It's also known as cytochrome BC. Now, succinate dehydrogenase sits here on the internal membrane of the mitochondria. Here's the cell cytosol. It changes succinate to fumarate. So mutations in any one of these things will cause this enzyme to be dysregulated, but it depends on where the mutation is that determines the phenotype. The most common mutation for pheos are mutations in B and D, leading to increased succinate in the cytosol. Interestingly, or profoundly interestingly, and if you ever hear Dr. Linehan at the NIH talk about this, he gets very interested in this, is that this links the genomic mutation of VHL with pheochromocytomas, explaining why patients with VHL can develop kidney cancers and pheochromocytoma. You can see here that succinate migrates out into the cell. It interferes with peroleal hydroxyl dehydrogenase, and then interferes with a degradation of HIF1 alpha, and HIF1 alpha goes on to make all those wonderful proteins that lead to cancer phenotypes. So clearly, when we see these patients, the most common finding is a sporadic pheochromocytoma seen in about 2/3 of patients, but the rest are germline mutated positive patients. And we have to be aware that sometimes these patients have to be screened and be counseled appropriately by a geneticist who is CLIA approved. VHL and the PGLs are the ones that go through succinate dehydrogenase, whereas von Recklinghausen's disease and MEN2 go through apoptotic escape. Now, importantly, we know that catecholamines are the critical chemical required to manifest pheochromocytoma, but they were not easy to identify, far more difficult to identify than the cortisols. And here is Johns Hopkins Dr. Abel. Here is checking his text messages, as I'm sure we all are this morning. He identified catecholamines as early as 1905 with the help of this lovely biochemist named Jokichi Takemine. Now, he was not only a Japanese biochemist, but an incredibly important New Yorker who was involved in a lot of philanthropy, not the least of which was donation of 2,000 cherry trees to Washington, D.C. So here's a short intermission, and now we'll move on. So Takemine's role was to not only identify the catecholamines, but also leading to the articulation of how these precursors lead to norepinephrine and epinephrine. Now, it's very important to note that norepinephrine turns into epinephrine only because of the activity of this enzyme PNMT. Now, PNMT is not present in von Hippel-Lindau tumors or in paragangliomas. And for that reason, those patients will not have elevated epinephrine. So that's an important distinction. If you see a patient who has a pheochromocytoma and you get plasma epinephrine and it's normal, but the norepinephrine is elevated, that may be a VHL pheo, as opposed to an MEN2 or a von Recklinghausen's pheo. Now, here's a large left-sided pararenal mass that we took out. And unlike adrenal masses, when you divide the adrenal vein, the whole thing opens up like a little book. With this, we identified veins, and there are many of them, and divided them, and there was no movement. There was no opening of any book. And the reason is because this is not a pheochromocytoma. This is a paraganglioma. So these generally are more medial. They generally are in other ectopic sites of wherever the sympathetic chain had them develop. And they're very tenacious. They don't come out easily. We've only done 7 of these, and 3 of them were converted. So you can see here that the workup most commonly is going to be your plasma metanephrines and your 24-hour urine catecholamines. Now, if these are normal, repeat them. And sometimes people repeat them a 3rd time just to demonstrate the consistency of their elevation. And some endocrinologists will say that borderline elevation in these studies is not diagnostic. You have to repeat them anyway. But clearly what we're looking for now are the metanephrines. These are the urinary metanephrines, but we want the plasma metanephrines as well. Imaging on the in-service exam, it's almost always MRI. You can see here, this is a T2 weighted image. You can tell because the spinal cord is bright. And it's felt that often, but not always, pheochromocytomas tend to enhance with T2 weighted imaging. And that helps, especially when they're small. And this pheo is coming out. But if you have a 2 centimeter mass that's enhancing on T2 weighted imaging, that's suspicious. When you're worried about recurrences or multifocality or ectopia, an MIBG scan is indicated. I've only ordered 3 of these and never have they worked. And the nuclear medicine doctors often say that these are exceedingly sensitive to any type of antihypertensive agent, even agents that you don't think are antihypertensive. Even gabapentin for pain can cause an MIBG scan to go from weak to negative. And so if you have a patient who you really feel has multiple lesions or has recurred, you did an adrenalectomy and the catecholamines are still elevated, and you get an MIBG and it's negative, the nuclear medicine doctors may say, get an octreotide scan. And some forms of PET scans can actually see them. But the MIBGs are classically used to look at multifocality, but are exceedingly sensitive to doing the test correctly. The in-service used to have pictures, no longer, but this is a classic finding on pheochromocytomas, this well-circumscribed ball of cells, known in German as the Zellballen. And then other predictors of malignancy, the larger the tumor, persistent hypertension after an adrenalectomy, persistent catecholamines after an adrenalectomy, production of a enolase called snail. This is generally not predictive, but associated, and the presence of metastases. So if you look up in Campbell's, what is the strongest indicator of malignancy? It's the presence of metastases. That's not particularly helpful when you're trying to prognosticate of a patient who's had a solitary lesion, but it is definitely a sine qua non of malignancy is metastatic pheo. They most often go to the lymph nodes, liver, lung, and bone. Pathologists should be able to give you a pass score, a pass value. The higher this is, from 0 to 14, the more likely it is this is a malignancy. Now, surgery for the pheochromocytomas is obviously exciting not only for the surgeon, but for the anesthesiologist. Charlie Mayo was the first to take one out in 1926, a famous patient. She lived many years after the surgery, but he was astounded at how vascular these lesions are. Probably not just vascular, but also friable, that they tend to fall apart very easily. It's one of the reasons why the vasculature is attacked first. Now, the workup for these patients really should occur weeks before you want to do an adrenalectomy. It's very rare that you'll have to do an adrenalectomy in somebody who's acutely sick. Now, the Germans who've done in Essen under Dr. Waltz has done 2,500 pheos, and they feel that any of these preoperative maneuvers, alpha blockade, beta blockade, can worsen the intraoperative experience, and that these patients show up to your doorstep having had decades of adrenal crises and have survived, and therefore should find no better area for control than in the operating room. And so they almost never do the things that we do here, which is start them on an alpha blocker. Now, phenoxybenzamine is very expensive. It's $100 a pill because it's an orphan drug. A lot of endocrinologists just give 8 milligrams of Cardura twice a day. A few weeks later, add Rapamil. Maybe a day or two later, you can add a beta blocker to protect the heart. Get them admitted to the hospital for hydration. These are almost always volume contracted patients, and they need to have intravenous fluids to get their urine-specific gravity down to 1010, 1012, something like that. And very often, insurance companies will approve, pre-admission for volume because of this syndrome. You need to have your cardiac anesthesiologists. Also tell them when you're dividing the adrenal vein, the blood pressure may drop, and it's often taught that the anesthesiologist gives them pressure, but actually on the in-service exam and on the recert I just took, the answer is actually you give them a bolus of volume of saline or half normal saline. So open techniques are rather infamous. These were huge lesions. a right subcostal incision, getting into the space behind the liver, lifting up the triangular ligaments to free up the liver. This is really dissecting the liver away from the adrenal gland. Elevating the patient away from the tumor was classic findings. To get to the right adrenal, you have to mobilize the duodenum immediately to find it, and then, of course, dividing the inferior pedicle. On the left side is a little more challenging. These are old. These are from the National Library of Medicine. These were 1973, 1975 surgeries. So you can see the patients had to undergo a lot to get a 1 centimeter mass out in an MEN2 patient. So we have to thank our predecessors, but we also have to thank progress. Most common way, of course, now is a laparoscopic or robotic way. Our friend Suresh Baryame down in Alabama just wrote a paper showing that the robotic patients tend to be larger. They tend to have less blood loss than the laparoscopic cases, have a similar length of stay. Whatever you're comfortable with. You generally can do these cases with only a ligature. This is an interesting approach by Dr. Waltz and Essen. This is a case in which you're approaching the adrenal gland posteriorly with the patient not only prone, but the jackknife position. And you insufflate the retroperitoneum with up to 30 millimeters. So the patient can really tolerate this. And so everything is flipped over. You can see here that this is an approach to the right adrenal. So you can see here that the vena cava is to our left, and so everything is flipped over. The kidney is down, the adrenal is up, and the only two instruments they use besides the camera are the ligature and the elevator. When you're done, you can see the patient in the jackknife position, and this is very important because you need to open up the space. You can see that in this case of single access surgery, you really only have one lesion, one incision. So in the last 3 minutes, we just have a few questions. Conclusions, of course, incidentalomas require systemic consideration and workup. Invasive testing is really only done for equivocal cases or cases in which you suspect functionality. Screening is only done for patients with pheochromocytomas, and certainly consider pheo even briefly before you undergo any kind of adrenalectomy. Not all pheochromocytomas have hypertension, and that should be considered, especially when you see a lesion that enhances on an MRI. Suspect malignancy in any case of an adrenal mass with virilization. Suspect Conn's tumor if you have lethargy and myalgias. Often patients have been treated for low potassium with K-DIR, so you don't see that as much. Prepare for an Addisonian crisis. If you're doing a lot of partial adrenalectomies, you may not have left a lot of functional adrenal behind. And if you get to the post-op area and you find the patient crashing from shock, hypotension, fever, they may not be bleeding to death. They may actually just be Addisonian, and stress dose steroids ought to do it while you're working them up for obviously more surgically important reasons. So here are some in-service questions from our last 90 seconds. What is a clinical feature that may distinguish Conn syndrome from Pheo's? Well, they're both hypertensive, so it's not the degree of hypertension. A lot of people who are older develop cardiomyopathy. Almost all patients with Pheo's do have cardiomyopathy. So it's not necessarily a distinguishing factor. Myalgias, unilateral disease. Very rarely will you have a Conn syndrome on both sides, but it's not unheard of. And mutations in SDH. So clearly, pheochromocytomas, you're not going to be doing mutations on SDH. So clinically, I'd say that the most common thing is myalgias. A patient with myalgia and an adrenal mass, that's probably a Conn syndrome, not a Pheo. The most common type of adrenal insufficiency, of course, is not from Addison's disease, very rare autoimmune diseases, not aging. It's what we do. It's iatrogenic. The most common cause of adrenal insufficiency is cortisol withdrawal from long-standing from adrenal treatment. After laparoscopic division of the left adrenal vein, a patient with suspected pheochromocytoma becomes hypotensive. The next best step is to head down, reduce the pneumo, give them sodium nitroprusside, give them a push of a pressor. Most people would say this. Most people would say give them catecholamines, but in fact, you give them saline. You give them a bolus of volume. 3 months after an adrenalectomy for Conn syndrome, laboratory values in a now normotensive person who's not on any medications may include which of the following. These drive me crazy. I generally like to guess the answer first and then look at the choices. So the possibilities here are two. One, everything's normal. The patient has a normal potassium and a normal creatinine. But in some cases, you can have an elevated creatinine and you wonder, gee, what did the surgery do? But in fact, this is the unmasking of underlying renal insufficiency is when you remove the aldo. And importantly, you can't check electrolytes too soon after an adrenalectomy for Conn syndrome. If you have a patient that stays in the hospital for 3 days, 5, whatever reason, and you check their electrolytes a week later, their potassium may still be low. It may take some time for the body's store of potassium to equilibrate. So just hang on. Okay, very good. So I wanted to I really have to thank the organizers of these talks. This is really a lovely idea, a wonderful idea, and I'm learning a lot from these lectures, and will continue to be a big fan of the Empire series. So thank you for the organizers and Dr. Al-Alao, and I hope you enjoy the rest of your day.
Thanks so much, Dr. Phillips. That was a wonderful review of the physiology, the pathophysiology, and the associated, medical history and history that ties in with the discovery of the diseases. I'm going to ask you some questions that were posted associated with your talk as we invite Dr. Whalen to start loading up his slides. The first question is there any role for biopsy when you're evaluating adrenal masses?
It's not uncommon for you to see a patient in the office who's had a biopsy, and it's consistent with the pheo. That is generally frowned upon, as obviously this can cause a crisis if something goes wrong. The only role for biopsy, of course, would be in those patients who suspect metastatic disease. This might be important for staging, may be important because in some cases in which the only site of disease is an adrenal met, you may be able to validate surgery. But we're not routinely doing biopsies for benign disease.
The next question is, what are your thoughts on adrenal cortical carcinoma and the approach to surgery? Is open preferred in those situations since there's this theoretical risk of seeding with the laparoscopic approach with the pneumoperitoneum?
These reports of metastatic disease from pneumoperitoneum are really anecdotal because the tumor is just so rare. But a lot of these tumors are really massive. I've only done 2 of them. They were both greater than 12 centimeters, so they're really not going to be amenable to a laparoscopic technique. They're amenable to a maximally invasive technique, and they're almost always involving surrounding structures. They almost always have to be treated as like a sarcoma. Our 2 patients lost the spleen, the distal tail of the pancreas, and the kidney. And so those are not exactly laparoscopic environments. For other lesions that are 5 centimeters, 8 centimeters, that seem to be amenable to excision, laparoscopy is certainly appropriate, but then you have to ask yourself, what is the benefit? What is the benefit here? Am I really trying to save the patient a large scar, get it out of the hospital faster? But there doesn't appear to be any obvious reason why a pneumoperitoneum would cause an adrenal cancer to become widely metastatic unless you're violating the capsule because of undue surgical tension.
Dr. Phillips, I'm going to just ask you to stop sharing your screen so the next speaker can start loading up his talk as I continue to ask you questions. The next question is, In your experience, is there any role for surgery for a large myelolipoma? The person is referencing a 13-centimeter large tumor. So even though this is benign, in your experience, have you offered patients surgery for this due to fear for spontaneous hemorrhage?
Yes, those two CAT scans were for patients we did adrenalectomies on because the patients had symptoms, and patients are actually willing to undergo the surgery because they believe that removing the mass will make them either breathe better or get rid of pain. And so they do have indications.
Sorry, hello?
It's okay. Continue speaking, Dr. Phillips.
The larger the space occupation, the more justified you are in doing an adrenalectomy. Obviously, you'd have to make sure that the patient's a surgical candidate because a lot of these lesions are rather large and may require an open retroperitoneal approach. So thank you very much.
Pleasure. Thank you so much for participating in the Empire series. Our next speaker is Dr. Michael Whalen from George Washington.